Welcome to Pediatric Grand Rounds on WebEx. I'm Suzanne Mazer, and I'm the director of CME here at Seattle Children's Hospital. This morning, I have the pleasure of introducing our three amazing speakers. The first is Dr. Donna Deno, who's a professor in global health and a professor in pediatrics at the University of Washington. She's the associate director of the University of Washington Global Health Adolescent and Child Health Center, representing the Department of Pediatrics. She serves as faculty continuity clinic preceptor for pediatric residents at Neighbor Care at Meridian, and her focus is on reducing healthcare disparities among vulnerable populations. She has served as consultant for the WHO, as well as Seattle-based international health NGOs on programs and policies related to child and adolescent health. So thank you, Dr. Deno. Next, I will be introducing Dr. Grace John Stewart, who is a professor of global health and medicine and epidemiology and pediatrics at the University of Washington. And she's the director of the UW Global Women, Adolescent, and Child Health Center. Dr. John Stewart's major research interest is in studies of HIV infection in Africa. She directs several large cohort studies aimed at defining mechanisms of HIV transmission between sexual partners and from mothers to infants in Kenya. Her group also focuses on maternal child studies, including the protective effects of breastfeeding, child growth and neurocognitive outcomes, preterm birth, viral infections with EBV, CMV, and TB. So thank you, Dr. John Stewart. And last but not least, Dr. Patricia Pavlinac, who is an epidemiologist and assistant professor in the Department of Global Health at the University of Washington. And she co-directs the gut health and child survival specific priority area of the Global Center for Integrated Health of Women, Adolescents, and Children. Dr. Pavlinac has extensive experience coordinating pediatric studies in Kenya, including her current director role in clinical trials, testing whether empiric use of an antibiotic improves survival and growth in Kenyan children. So thank you so much to our three presenters for being here, and to all of you in the audience. I'm going to mute my microphone and let our presenters take it away. Thanks so much.
Thank you to the chair, Dr. Leslie Walker-Harding, for inviting us to present at this Grand Rounds, and to all of you for joining us this morning. We really had been excited to see you in person, and we're still really glad to be talking to you on WebEx this morning, and excited to share some information about both the center and the topic of our discussion today. As was noted previously, none of the speakers have any items to disclose. And today we're going to focus on enteric infections and disease, what we think we know, what we don't know, and what we need to know. And again, I will provide a little bit in advance about the Global WACh Center. It's the Global Center for Integrated Health of Women, Adolescents, and Children. And importantly, we have our roots in three departments, including pediatrics, obstetrics, gynecology, and global health. And today we wanted to describe ways in which pediatricians and Global WACh can collaborate in global health research. We want to describe the effects of environmental enteric dysfunction on child health and survival, and describe methods to define the cause of death among children in low resource settings and the implications that this data might have on interventions to reduce preventable mortality. And finally, to spend a little time talking about challenges and opportunities in the prevention, identification, and treatment of Shigella infections among children in low resource settings. So what is Global WACh? Global WACh is the Center for Integrated Health of Women, Adolescents, and Children, and it's a mouthful, so that's why we shorten it to Global WACh. And we aim to contribute scientific discoveries, cultivate leaders with a very active program of mentorship, and then to bridge disciplines to advance the tightly connected health and well-being of women, adolescents, and children. And the way that we try to look at this is through the life cycle lens. And if you look at the top middle part of this slide, we have certain critical windows, and I'll be moving clockwise, that we think are important to address. So pregnancy and delivery, postpartum, mitigating the risk for maternal and infant death, and addressing things like illness and depression, particularly focusing on the first 1,000 days of life, which are very critical for the future of children. And then through childhood, the preteen period, the transition to autonomy, and eventually on through adulthood. With this life cycle approach, We often involve cohorts that include both women and children, and also have a growing portfolio of research in adolescents. So there are three scientific priority areas. A lot of our early work focused on HIV through the life cycle because of the epidemic particularly in sub-Saharan Africa, and has grown to include two other areas: a growing work in family planning decision support, particularly postpartum family planning decision support. And then what we're going to be focusing on today, a large scientific priority area focused on studies of gut health and child survival. All of our priority areas try to think about women, adolescents, and children, and there's a very big focus on adolescents that we won't be focusing on today, but hopefully in the future we can talk about that with you all. Certainly, our work is founded on very long-term collaborations. These are just pictures from Kenya, where we have an over 30-year collaborative partnership, and the aim of these long-term partnerships is to try to work together to address issues of public health importance. Currently, there are over 40 active grants, an annual budget of about 10 million, quite a lot of publications, 18 core faculty and staff all over the world. We work in countries predominantly in sub-Saharan Africa and Asia. Our leadership includes the co-directors, which are myself and Judd Walson, who's actually also the vice chair of the Department of Global Health, and associate directors in the Departments of Obstetrics Gynecology, Jennifer Unker, and associate director, Dr. Donna Deno, who's here in pediatrics and will be taking over from me on this presentation to dive into the topic that we're focusing on. And I'll hand it over to you, Donna.
Thank you so much, and thank you for the opportunity to be here this morning. We're a big department. Many of you may not know me. I'm faculty in the Division of General Pediatrics, also joined in the Department of Global Health, and adjunct in the Department of Health Services, both in the School of Public Health. I first came to UW and the Seattle Children's Hospital as a transfer resident in 1993. I also completed my MPH in the Department of Health Services at UW. Just to tell you a little bit about myself, I moved back to Ghana shortly after completing residency. I lived and worked in Ghana for 3 years at a rural district hospital for a year and as faculty in one of the medical schools and affiliated teaching hospitals for 2 years. These were exceptionally formative times in my career. Especially formative were my interactions with colleagues, young doctors at the time who've gone on to play vital roles in promoting health of children in Ghana and globally. I've had the further opportunity to work on many projects in sub-Saharan Africa and Asia, and I've been privileged to draw inspiration from health professionals doing amazing work to improve child health in their countries and worldwide, and it's been an honor to partner to try to support their efforts. Soon after returning to Seattle from Ghana, I joined the faculty in the Division of Gen Peds, which has been my home base since, other than the 4 years I lived in Geneva, where, among other things, I developed and taught a UW online course and did consulting work for the WHO. Big picture, I'm interested in how to improve health and health care to vulnerable populations and reduce health disparities, whether through advocacy, clinical or public health work, or research. And within the research realm, my work has largely focused on enteric infections, including in the US. In fact, Eileen Klein in the Division of Pediatric Emergency Medicine and Phil Tarr, formerly in the Division of Pediatric Gastroenterology here at UW and Seattle Children's and now at WashU in St. Louis, are my mentors and were my collaborators on studies here in Washington State to identify microbiologic etiologies of diarrheal illness. And our work on risk factors for pediatric sporadic bacterial enteric infections, such as those from Salmonella and Campylobacter, for example, these are widely thought of as foodborne illnesses, but our work identified environmental exposures to be as important as food-related exposures. My research focus includes not only enteric infections, but also gut dysfunction and their intertwined roles in childhood malnutrition globally, which I will speak to shortly. But first, Grace asked me to speak to how I became engaged in Global WACh research. There are a lot of faculty in the Department of Pediatrics doing very important and groundbreaking work in global health, many of whom are engaged with Global WACh. And just speaking to my own personal case, I think there were 4 factors that led to my engagement in Global WACh research. First, I have a research focus and expertise aligned with the emerging gut health, and child survival emphasis within Global WACh. Next, I teach the core graduate level maternal and child health in low and middle income countries course in the School of Public Health. And through that role, I teach and mentor grad students, including those enrolled in the Global WACh graduate certificate program. Next, my role as a consultant for WHO required intensive knowledge of WHO guidelines related to child and adolescent health and WHO's guideline development procedures. Finally, my clinical work on the ground in Ghana gave me a picture of how healthcare is delivered, how guidelines are adapted and implemented, research context on the ground, and connections with colleagues. These 4 skill sets and experiences provided the ground on which Global WACh collaborations grew. First, with Dr. Kirk Tickell when he was an MPH and Global WACh certificate student on a gap analysis of WHO malnutrition guidelines. Later, Dr. Patty Pavlinac invited me to join her EPI-PhD dissertation committee on pediatric diarrhea etiology in Kenya. And more recently, collaborating with Dr. Judd Walson on his multi-country cohort study to identify risk factors for poor outcomes among children with acute illness or undernutrition. Here I led efforts to ensure adherence to WHO guidelines of care at all 9 sites in 6 countries and co-lead the Enteric's working group. I'm excited about the opportunities for further linkages between the Department of Pediatrics and Global WACh and invite faculty in the Department of Pediatrics to reach out to me with suggestions on fostering partnering. With that as background, I'd like to tell you a little about 2 of the projects I'm currently engaged in related to environmental enteric dysfunction, or EED, previously referred to as environmental enteropathy or tropical enteropathy, and before that, tropical sprue, a term used to distinguish from non-tropical sprue or celiac disease. The change in terminology is meant to reflect the acquired nature of this disorder, which is triggered by an environmental stimulus. The exact etiology remains unclear, whether it's recurrent or persistent gastrointestinal infections or a specific pathogen, or maybe it's exposure to fecally contaminated environment with a load of enteric bugs that we don't even usually think of as being pathogenic. Regardless, as gluten is to celiac, an environmental trigger is to EED, stimulating an intestinal inflammatory response, leading to reduced mucosal surface area and malabsorption, as well as intestinal permeability, leading to translocation of microbes and microbial products from the gut to the bloodstream, resulting in a chronic inflammatory state. All of these processes contributing to undernutrition in children who are already at risk for food insecurity. EED, a largely asymptomatic disorder, is thought to be an important cause of child undernutrition, which is unfortunately still a pervasive problem globally. Evidence shows that only 1/3 of poor growth in children can be prevented or averted with nutritional interventions. We think that EED is a major cause of nutrition refractory poor growth. We believe it's critical to understand the pathophysiology of this disorder if we are to make further progress in reducing child undernutrition. Lack of assessments of the target tissue, the small bowel, has really hampered progress in understanding EED. Biopsy studies were used to initially describe this disorder in the 60s and 70s, but shifting research priorities, followed by concerns about ethical implications of scoping children without a clear rationale, resulted in a dearth of EED pathophysiology research until recently. In 2017, the Gates Foundation funded the EED Biopsy Initiative Consortium, which aims to better understand the pathophysiology of EED as a means to inform therapeutic targets and discover and validate less invasive biomarkers. The UW Department of Peds is one of the coordinating centers, and I had the opportunity to play the role of one of three coordinating investigators. The principal investigators span 5 recruiting sites across 4 countries and 3 continents. The EEDBI consortium is conducting the largest and most systematic approach to defining the histopathology of EED. The North American sites enrolled children presenting for endoscopy for various reasons, for comparison purposes. The sites in Asia and Africa enrolled undernourished children aged 6 to 18 months and provided nutritional supplementation. Non-responders received a medical workup, and if no etiology for their growth failure was identified, they were invited for endoscopy and biopsy to further their workup and confirm EED as a diagnosis. Histology slide images from those biopsies are uploaded to our study telepathology platform and read by a team of gastrointestinal pathologists using a novel multi-parameter scoring system for EED, which agnostically assesses tissue injury processes. The scoring system was developed and validated by the EED consortium. This quantitative scoring system will allow us to relate the EED histopathology to immunohistochemistry, transcriptomics, and microbial interrogations, as well as to markers from less invasively obtained specimens, such as from stool, urine, and blood, in order to inform future studies of EED that cannot deploy endoscopy and biopsy. We anticipate these data will be available in the coming year and hope that they'll inform intervention targets for this neglected and consequential disorder. The PIs and their key co-Is are doing a tremendous job leading these studies across the consortium, along with their teams whose activities span engagement with community leaders, community-based screening for eligible children, delivering the nutrition intervention and clinical workup, conducting the endoscopies, and managing all of the specimen analysis and data management. Now, I'd like to introduce you to another study based in Malawi, where we're using minimally invasive autopsies, also known as minimally invasive tissue sampling, or MITS, to better understand cause of death among children hospitalized with acute illness and/or undernutrition. More than 5 million children under the age of 5 die every year, the vast majority in low and middle income countries, and our understanding of cause of death is woefully limited. MITS is being used by researchers as a tool to better delineate childhood cause of death in order to inform interventions to reduce mortality. The MITS technique involves transcutaneous sampling of organs and leaves no disfiguring marks on the body. The technique has been found to have good validity compared to full autopsy, is less resource intensive, and is more acceptable to families compared to full autopsy, which is rarely deployed in low resource settings. The current MITS procedure, being used by a number of investigators globally, consists of sampling brain, heart, lung, liver, bone marrow, blood, cerebrospinal fluid, sometimes kidney and urine. The first thought I had when I learned about MITS a few years ago was, what about the GI tract? How can we understand the contribution of intestinal pathology in child mortality if we ignore this entire organ system? Of course, variable abdominal anatomy does not facilitate transcutaneous sampling, and furthermore, with the extensive length of intestines, identification of mucosal lesions in patchy diseases, which EED is thought to be, could be like finding a needle in a haystack if one could not simultaneously visualize the mucosa. Our experience in the EED biopsy consortium led us to think, what about a post-mortem endoscopic approach to the GI tract? Now, you may be thinking this sounds crazy. We did hear that a lot. You're going to endoscope in the mortuary? Will that even work? Can you intubate the GI tract, whether from above or from below after death and in an unprepped child? The next critique was, even if you can obtain intestinal tissue, won't it just be completely autolyzed? After all, intestinal mucosa is the first to degrade post-mortem. And there's an urban legend in the literature that intestinal tissue obtained after 12 hours post-mortem would be mush. That's my technical term, mush. But we were determined to try because we felt that we just couldn't ignore the role of the GI tract as a contributor to child mortality. We set out to determine if postmortem endoscopy and biopsy is feasible, and if so, what can we learn about intestinal pathophysiology in these cases that can contribute to reducing child deaths. We've completed enrollment in our MITS and Malawi study, and we're just starting data analysis, but I can provide you with some preliminary results on the first half of the cases. I know this is a busy table, but starting on the right column shows a list of diagnoses among these 14 cases, and then moving leftward, the next column is the postmortem interval to the start of the endoscopy, endoscopy procedure. And you can see that 12 out of the 14 commenced before 12 hours postmortem. And then moving further leftward, you can see the various parts of the GI tract where we attempted to sample. You can see that GI biopsies were obtained endoscopically in all cases. In the stomach, 13 out of 14, the duodenum, 13 out of 14, the colon, less frequently successful, only 4 out of 14, and then the rectum in all cases. So we did show that this is a feasible approach. Now the next question is there anything meaningful that the histology tells us, or is tissue completely degraded? The purple coloration tells you the degree of autolysis in this table. So the lighter the purple, the better preserved, the more autolysis there is, and the darker the purple, the better preserved the architecture is preserved. All cases did demonstrate at least some autolysis, though to variable degrees, and we were not able to identify a relationship between postmortem interval or diagnosis with the degree of autolysis, but we'll be looking at these factors and other factors in the complete data set. So while villus architecture and epithelial cells were almost universally degraded, other features can be more readily assessed, including crypts, acute and chronic inflammatory cells, Brunner glands, which protect the mucosal lining of the duodenum, and sometimes Paneth cells, which may play an important role in host defense against microbes. We have electron microscopy on one case thus far, and tight junctions and subcellular features are visible. We are now leveraging the telepathology and scoring systems developed for the EEDBI consortium to score the MITS intestinal images and relate this to clinical characteristics and microbial assessments of the intestinal tissue. We hope these data will be ready to share within a year and that they'll lead to improved care and outcomes of hospitalized children. So before I turn it over to Patty to talk about one of my favorite topics, diarrheal disease, I want to acknowledge that neither of these studies nor any of the other projects I'm involved in could happen without the incredible partners and leaders on the ground. And with that, I'd like to turn it over to Dr. Patty Pavlinack to talk about her work on diarrheal disease.
Thanks so much, Donna. I will just share my screen. Okay, hi everybody. I too am thrilled to be here today and really grateful that you're willing to join despite all that's going on in the world today. So as mentioned, my name is Patty Pavlinack, and I'm an assistant professor in the Department of Global Health and co-director, along with Dr. Judd Walson, of the Global WACh Gut Health and Child Survival Scientific Priority Area. I'm an epidemiologist and did my master's and PhD training here at UW after 2 years in the Peace Corps in Guyana. And I've really never looked back after integrating into the Global WACh Center, first as a student and now as a faculty member. I'm a member of a very large team of Seattle and Kenya-based researchers, as many of us are in the Department of Global Health. And while I'm here today to represent the research our team is working on, it's so important that I acknowledge that I'm only a very small cog in this very large wheel of epidemiologists, pediatricians, microbiologists, clinical officers, nurses, laboratory technicians, and counselors who are conducting research related to gut health and child survival in Kenya. To frame some of the research our team is working on, I thought it would be good to start with a case. Elizabeth is an 18-month-old female presenting to Kisii Teaching and Referring Hospital in Western Kenya, shown here, with watery diarrhea, severe dehydration, and fever. She's had this diarrhea for the last 3 days, is moderately undernourished, has no evidence of edema, and is up to date on her immunizations, including rotavirus, which has been rolled out in Kenya. There's no access to bacterial culture nor molecular diagnostics for this child, as is the case particularly for enteric pathogens in many low-resource settings. Therefore, clinicians syndromically manage diarrhea following the Kenyan Ministry of Health guidelines, which are largely based on the World Health Organization guidelines, which are shown here. Because Elizabeth has severe dehydration, she is rehydrated intravenously at first and then moved on to oral rehydration, and she's carefully observed. She does not receive an antibiotic because she does not have either of the two indications for antibiotics according to these guidelines. Those two conditions are dysentery, defined as presence or history of blood in the stool, or suspected cholera. So in continuing with Elizabeth's case, she goes on to receive IV rehydration, as I mentioned, and is discharged the next day after being fully hydrated and afebrile. She's presumed to recover well at home. Upon discharge, Elizabeth receives nutritional counseling, again, as recommended by the WHO guidelines, because her nutritional status does suggest she has some moderate risk, and receives counseling on if and when to return to seek care at this facility. Those recommendations are to return if Elizabeth's conditions worsens, if she's unable to drink or eat, if she develops a fever or begins to have blood in her stool, or just generally doesn't improve after about 5 days. Elizabeth then worsens 4 days after discharge with new hotness of body and abdominal cramping, but the mother can't afford transport to return to the hospital after spending the household income at the last hospitalization, and Elizabeth succumbs at home. We don't know the cause of Elizabeth's death because no autopsy is performed, nor a verbal autopsy, and the only medical records we have access to are those from the recent hospitalization. And for all that we know, Elizabeth seemed fine at discharge. So this tragically is not an uncommon chain of events in many of the settings where we work. And when we think about diarrhea-associated deaths in these settings, we tend to think about deaths, of course, due to dehydration. So deaths that are due to a very acute process. However, about half of the deaths that occur in the months following an episode of severe diarrhea, like Elizabeth's case, do not follow this classic acute trajectory. What often happens is a child recovers, at least clinically, from the dehydration and diarrhea, only to die from another often unknown insult in the subsequent months. So what I'm showing here is a mortality framework that's attempting to disaggregate acute from post-acute processes of death, at least associated with diarrheal disease. And these mortality processes occur within a context, of course, of children often living in poverty, frequently in environments with fecal contamination leading to subclinical disease states, such as EED, as Donna was mentioning. And therefore, the diarrhea really is only the tip of the iceberg in terms of a child's vulnerability. So our group really strives to address these vulnerabilities from multiple angles. ranging from interventions for the identification and management of malnutrition and EED, enteric infections, improvements in discharge care, and the important mechanistic work, such as what Donna was describing, to inform the interventions for these processes. What I'll focus on with you are two areas of research that I'm directly involved in, namely the identification, management, and prevention of enteric infections, specifically Shigella infections. So a little background on Shigella. The recent use of molecular techniques to identify enteric pathogens have led to a shifting of our understanding of the leading causes of diarrhea in children in low and middle income countries. Specifically here, I'm showing the leading causes of diarrhea among toddlers in Kenya. And on the left are the causes using traditional methods for diagnosing, which for Shigella is bacterial culture. And on the right is using quantitative PCR. So with the use of molecular methods, we've learned that Shigella is the leading cause of diarrhea among 12 to 23-month-olds in sub-Saharan Africa. And just as an aside, because I'll be mentioning bloody diarrhea and the management of bloody diarrhea in Kenya, it's important to note that these etiology studies have really shown that EHEC is extremely rare in low and middle income countries, so it's not something we really think about a lot. So going back to Shigella, modelers at the Institute for Health Metrics and Evaluation here at UW estimate that Shigella diarrhea causes over 50,000 deaths in children per year. And among children who survive shigellosis, Shigella is implicated in growth faltering. And its detrimental impact on growth, interestingly, seems to be more extreme than other enteric pathogens, for reasons that likely involved its somewhat unique impact on the enteric system. I mentioned this briefly when discussing Elizabeth's case, but just as a reminder, the WHO guidelines for diarrhea recommend antibiotics only for suspected cholera or dysentery. The dysentery guideline was based on evidence that children with blood in their stool living in low and middle income countries had a high probability of Shigella infection being the cause of the diarrhea, and that they responded well to antibiotic therapy. Our group became interested in a slightly different question of whether blood in the stool is missing Shigella infections that should be treated. And to answer this question, we conducted a cross-sectional study in Kenya among just under 1,500 children with diarrhea, and found that of the 63 culture-confirmed Shigella cases, only 7, or 11%, presented with or had a history of blood in their stool. So this left 90% of Shigella-infected children without an antibiotic indication according to their guidelines. This finding led our group to conduct a systematic review of other studies reporting the sensitivity of dysentery for Shigella, a Shigella syndromic diagnosis. And we found that most studies to be reporting a sensitivity of about 40%, and that the ability of dysentery to identify Shigella has actually gone down over time, as is shown in that downward trended line. And we think this is due to a shift in the serotypes, the prominent serotypes of Shigella as countries develop. Shigella dysenteriae type 2, which is a major cause of epidemics of dysentery, are really rare serotypes now, and most of the serotypes of late are Shigella flexneri and Shigella sonii, the latter of which is really unlikely to present with blood in the stool. So these findings, along with the use of molecular diagnostics for Shigella, have led the field to appreciate that there is a large burden of non-dysenteric Shigella infections. And it's not clear how they should be identified with the absence of diagnostic tools, and really how they should be managed. Our group is part of a study hoping to address the management side of this question in a very large randomized controlled trial of azithromycin for children with watery diarrhea and either malnutrition or dehydration, two risk factors that we know are highly associated with acute and post-acute mortality following diarrhea. This multi-country WHO coordinated trial is following children for 6 months to evaluate the impact of azithromycin on mortality, growth, and importantly, antimicrobial resistance in E. coli and nasopharyngeal bacteria. With stored samples, we'll be conducting quantitative PCR to determine etiology. And so in the subset of children with non-dysenteric Shigella, we're going to be evaluating the impact of azithromycin. So circling back to the case we discussed earlier, it's very possible that Elizabeth's diarrhea was caused by Shigella, that she had underlying EED prior to or following the Shigella infection, explaining her undernutrition, and then died in this post-acute pathway to death despite recovering from the dehydration. In Elizabeth's case, there was likely a missed opportunity for her to receive an appropriate antibiotic, which may have been life-saving. So the Gates Foundation and other really important international stakeholders are putting significant investment into Shigella vaccines, particularly for the target population of children under 5 years. There are a number of vaccine candidates that are currently being tested for safety, dosing, and immunogenicity in human challenge models in adults. And we're really hopeful that at least one of these vaccine candidates is going to emerge as being ready and safe to test in large trials among children living in Africa and Asia who stand to benefit the most from these vaccines. One key area that our team is involved in is helping to inform the various policy, research, and industry stakeholders in identifying the target product profile for Shigella vaccines in children under 5. This is a target product profile from 2016, which is currently being updated. But a key element of this target product profile is obviously defining the target efficacy estimates, which are between 50 and 70%. However, there's not yet agreement in the field about how these upcoming trials are going to define severe disease of Shigella for the purpose of these trials and how to confirm Shigella in these trials microbiologically. And these are the types of questions that epidemiologists think about a lot, and our group of epidemiologists and pediatricians are really working together to try to address. So just briefly, the Sakari score, many of you may know, it's basically a research tool used to define severe rotavirus diarrhea. And so one area that our team is working on is determining how this current score performs in children with Shigella using existing data sets and comparing how its performance to other possible severity scores that could be used for Shigella vaccine trials. And as I mentioned, there's not yet consensus also on what appropriate microbiologic endpoint will be in these Shigella trials. So our group is also determining the proportion missed by culture and the implications for this lack of sensitivity for key determinants of vaccine trial planning, such as sample size estimation. So just to bring it back to Elizabeth's case and the mortality framework that our team strives to further characterize and intervene upon, there are a number of critical windows in which interventions would have likely been life-saving. I named a couple. Some of the work our team is also doing that we did not mention today is around the identification and management of malnutrition in communities using mobile health technologies, as well as efforts in improving discharge guidelines and follow-up care and further elucidating the role of enteric pathogens and antimicrobial resistance in pediatric outcomes surrounding a hospitalization. So in reflecting on the last number of years of pediatricians and epidemiologists working together on research in our Global WACh Gut Health and Child Survival group, I see there being both complementary and discrete skill sets that pediatricians and epidemiologists bring to the table. And the successful melding of these two disciplines really can lead to what I believe to be incredibly impactful research. And, you know, I've tried to highlight some of the people that we work with, are writing grants with, or trying to do research with, both in the Department of Pediatrics and the Department of Global Health and Epidemiology. So I think I'll leave it there. We've included our contact information here. Kate Fisenmeyer, who is the Managing Director of Global WACh, is a great person to contact for information about the center and can triage questions to appropriate teams. And then we've also included mine, Grace's, and Donna's contact information. And we'd just love for you to reach out if you think there are opportunities for collaboration, or simply if any of you want to brainstorm about improving outcomes in children with enteric infections. So now would love to hear questions or thoughts.
And we do have a question from Ellen Pasloff. Thank you so much for the great talk. I saw mention of giving, I'm not sure what this means. I saw mention of giving zinc at discharge. Is there a role for zinc supplementation in diarrheal disease? Maybe elemental zinc?
Such a great question, and I really should have mentioned that more. So actually, the WHO guidelines recommend a 14-day course of therapeutic zinc being given to all children with diarrhea, kind of irrespective of other clinical signs and symptoms. And that's based on evidence, randomized controlled trial evidence from mostly the 90s and early 2000s, showing that therapeutic zinc in the context of diarrhea can improve time to diarrhea resolution and can improve recurring diarrheal episodes, and in some trials actually reduce risk of acute respiratory infections. You know, I don't know that we fully understand the mechanisms of that, and there is question now of whether that guideline is still important, and as zinc deficiency has declined in some settings. WHO has conducted a trial of comparing a much shorter course of zinc to that 14-day course, because one thing we've learned kind of from the programmatic side of diarrheal management is that 14 days is really too long, is an unrealistic target. And zinc also can cause vomiting, so there's not great adherence to that guideline. So we're eagerly awaiting the results to see if a shorter course will be sufficient. The role of supplemental zinc instead of kind of therapeutic zinc for diarrhea, that's a question that I'm not as familiar with. Donna, I wonder if you wanted to add anything about supplemental zinc, or therapeutic zinc for that matter.
No, I think right now there are no guidelines around supplemental zinc, although there's work being done to investigate whether or not that would be a better option. Not a better option, an additional option. I see there's quite a few other questions coming in. This is really great.
Yes, thank you. So how has this work informed our work here? How can we at Seattle Children's better partner with Global WACh in pediatrics?
I can take that second question about partnership. I think we would all love more partnership, and it's been a great partnership already with pediatrics. There are a lot of seminars that people are welcome to join about different aspects that may be of interest to different stakeholders in pediatrics, including the Breakfast with WACh seminars that go deep into some of the research priorities that we focus on. There's an end of year event that we had hoped to have in June that will be postponed to fall, that will bring some leadership from WHO and other seminars in family planning that we can make people aware of if they join the listserv. There's a lot of work, as I mentioned earlier, in adolescence and expanding work in family planning for people who are interested as well.
Thank you. And then a couple of questions that are similar. One is, have you seen a rise in C. diff infections with increased antibiotic administration? And then another, any other unintended consequences of more liberal antibiotic usage?
You know, I'll probably ask Donna from a clinical perspective to back me up, but to the best of my knowledge, we don't really ever think about or see C. diff in the diarrhea setting in the settings that I work. Whether that's because we're not looking for it or not, I'm not totally sure, but I think we feel pretty confident that these enteric pathogens that are found in contaminated environments are really the leading causes of diarrhea. Donna, do you want to correct me or add anything to that?
No, Patty, I don't really have anything to add. I don't know that
Okay.
increased was found in the other trials like the AZM community-based azithromycin trials, where they gave azithromycin at a community level on a I think it was every 6-monthly basis, right?
Yeah, and I don't think they're looking at C. diff or
Yeah.
any pathogens for that matter. Yeah, they're just looking at mortality generally. Great question. Yeah, something we'll think about, and if I come up with more information, I can send that to this group somehow.
Thank you. We'll keep going. For the minimally invasive tissue biopsy sampling, are you obtaining pulmonary samples through direct needle aspiration through the chest wall? That's Indy's question, not GI related, sorry, but curious about respiratory pathogens as cause of death as well.
Yeah, that's a great question. All of the other samples are being obtained per the routine MITS procedure, which is transcutaneous sampling. And so we are obtaining through the chest wall on the right side and the left side. The samples are being assessed by histology as well as microbiologically using the TACMAN array card, so PCR method. And we actually just analyzed the first 6 pulmonary specimens using the TAC card. So that work is ongoing. Yeah, we're very interested to see what these results show. We're also using the TAC card to analyze blood, cerebrospinal fluid, nasopharyngeal swab, stool, and we're, as far as I know, the first group that's going to be using the TAC cards to assess microbiology used in intestinal specimens.
What formulation do you prescribe for zinc here in Seattle?
I think that's a really great question. The recommendation for zinc in cases of diarrhea is in settings where it's believed that there's a high prevalence of zinc deficiency. So it's not a recommendation generally in high income countries. And in fact, I had a patient a couple of years ago who presented with severe watery diarrhea at Neighbor Care Meridian, and the patient had just immigrated from South Asia. And when I tried to find a formulation of zinc to provide for this child, it was really quite a thrash. But anyways, just to say that it's not something that we would be routinely prescribing here in Seattle.
Thank you. And then last question for now. Do you believe that the rollout of rotavirus vaccine has reduced Shigella-related mortality by decreasing the number of hits of diarrhea disease in young at-risk children?
Yeah, really, really good question. So rotavirus vaccine trials have shown a decrease in diarrheal episodes, even those not caused by rotavirus, which does suggest that there's this protection from just, reducing pathogen hits, enteric pathogen hits. There's protection kind of for other types of enteric pathogens. So I definitely think rotavirus vaccine has decreased diarrheal mortality, not specifically Shigella diarrheal mortality, but overall diarrheal mortality. And I think we expect the same to happen with Shigella, particularly with Shigella vaccines, particularly because Shigella vaccines do seem to have this really strong association with underlying malnutrition, which we know increases children's risk of death. So these pathways are, both direct and indirect, and so it will be important to think about as we design these trials. I was also looking at the chat box, and I realized I didn't address the second part of an earlier question around unintended consequences of more liberal antibiotic usage. And this is a really important question. And in the diarrhea world, we think about this a lot because, I showed the guidelines and how rare the indication is for antibiotic use in the guidelines, but the reality is antibiotic use for diarrhea is quite high for a number of reasons. One is there may be a lot of self-treatment with antibiotics because antibiotics are often available in local pharmacies without a prescription. But from the clinical perspective, interesting, the conversations I've had with a lot of pediatricians is, given kind of the case example I shared, they're very well aware that a case like Elizabeth has a high risk of doing poorly. And even though the guidelines suggest that she should not receive an antibiotic, if they're aware of her situation or financial situation, she's unlikely to come back to the facility if something goes wrong. So often children are receiving antibiotics for diarrhea, but we think they're not the right antibiotics, that whatever antibiotics are available, the enteric pathogens are probably resistant to, and or that we don't really have good evidence-based guidelines to inform which children should or shouldn't get an antibiotic. There's been some really interesting work in the pneumonia world showing that actually if you have evidence, you have randomized control trials informing the indication for antibiotics and clinicians trust that those guidelines are evidence-based, that there's actually a decrease in the use of antibiotics, which may seem counterintuitive. So with that trial that I shared about that's being done by the WHO, that's part of the rationale, is actually feeling like if we had true large trials answering this question, it might actually reduce antibiotic use. But of course, we're interested and eager to look at antimicrobial resistance, and that's in the front and foremost of our mind, and will always need to be weighed against any benefits we see on an individual level of antibiotics.
How have families and local communities responded to the reintroduction of EGD to the malnutrition workup of some children in these lower resource settings?
Yeah, that's a great question. What we hear from our investigators on the ground in Malawi, Bangladesh, and Pakistan is that it's been very acceptable, that the vast majority of families who are offered endoscopy after the kids are not responding to the nutritional intervention and have a negative medical workup, that they are generally positive about the endoscopy, and that the acceptance rate has been very high. I really, this question has not been asked, but it might be something that people are wondering about as well, about the acceptability of the MITS procedure in Malawi, which honestly weighed very heavy on my mind when we introduced this study. But it's actually we've had about approximately 40% acceptance rate. So it's been fairly well accepted. And many families who decline the procedure is because of the timing, needing to get back to their home village for burial rites, etc. And then the families that we followed up with, we always follow up with the families after the MITS procedure. We follow up with them 3 days afterwards to check in to see how they're doing. We have a team that especially trained to do the counseling, and then we follow up with them 4 to 6 weeks later, and they've generally been really appreciative of the team and the engagement, the MITS team and the engagement from the MITS team.
I'll just follow up with one last thing about the C. diff question. So just in looking at the quantitative PCR card that we use and all the pathogen hits, it does look like we are testing for C. diff in these settings, and it's not coming up as very often. So we feel pretty confident that C. diff is currently not a problem.
I will just say thank you so much. So thank you to Dr. Walker-Harding, who brought this topic and these speakers to my attention. Thank you so much for all 3 speakers for being here, and for everyone who has joined us by WebEx. We really appreciate you all the great questions, and everybody have a good week, and we will talk to you all next week. Thanks so much, everybody.